Hello, ma'am, am I audible, ma'am?
Yes, you are audible. Yes, you are audible.
Ma'am is in Vice Chancellor's chamber. She could just join us shortly.
Yeah, sure. No problem.
Let's begin with this, ma'am. There is 5 minutes.
Sangeeta, am I audible? Sangeeta is there?
Yes, I'm there, Professor. I'm there.
Sangeeta, if you remember, I happens to be a senior in Bundelkhand University. पहचान लिया? आवाज आ रही है?
Your voice is breaking, Professor Singh. पहचान लिया।
ओह,
जी, अब आ रही है आपके पास।
अभी आ रही है? अभी मेरी आवाज
आ रही है।
हाँ, याद आया कुछ?
जी, आ रही है आपके पास। या।
Okay. So how are you?
I'm fine. How are you, sir?
I am also very fine. शायद मुझे याद आ रहा है, 1-2 बार मैंने बीच में बात की है, कभी बीच में।
या।
जब आप खड़गपुर में थी तब, है ना?
मैं अभी भी खड़गपुर में ही हूँ।
अभी खड़गपुर में ही है। मैं सोच रहा था कि शायद आप राजस्थान चली गई थी, इसलिए दिमाग
नहीं, मैं लियन पे गई थी 2 साल के लिए, वापस आ गई। जी।
ओह, वेरी गुड, बहुत अच्छी बात है। और सुजॉय भट्टाचार्य वो मेरा स्टूडेंट था।
ओके।
तो उसको मैंने पढ़ाया था हरिद्वार में।
ओके, अभी वो
तो
लंदन में
है ना, अब्रॉड में है ना, यूके में है वो।
जी, अभी वो लंदन में है। जी।
चलिए, बहुत अच्छा लगा। ठीक है, विल कीप इन टच।
श्योर।
अब बीच बीच में आप जाती रहती झांसी की नहीं? बिल्कुल ही बंद कर दी?
जाती हूँ। अभी 2-3 साल से नहीं गई हूँ, पर वैसे जाती हूँ।
नहीं, मेरी मुलाकात होती है, पूना मैम से होती है, AK सक्सेना सर से तो बात ही होती रहती है फोन पे।
नहीं, मैं अभी बस जब से पेरेंट्स उधर से मूव हुए हैं, तब कभी जाना होता है, वो कम। एंड घर तो है अभी वहाँ।
हाँ, शैलन निगम सर इस टाइम नागपुर में है।
या मुझे मालूम है। जी।
हाँ। तो यही है, RK सक्सेना सर लखनऊ रिटायरमेंट के बाद रह रहे हैं। बाकी नए लोगों को तो आप भी नहीं जानते, हम भी नहीं जानते, कुछ लोग वहाँ पर हैं।
जी।
लास्ट ईयर हम लोग गए थे, एक गैदरिंग की थी वहाँ,
ओके।
अपना रीयूनियन किया था। तो वी आर वेल कनेक्टेड, और मैं तो चाहूंगा यू शुड आल्सो रिमेन कनेक्टेड विद अस।
थैंक यू। या श्योर।
हाँ, ओके।
Tanya from IIT Kharagpur. With your permission, we may start.
Yeah. Please do so, ma'am. Please do so.
Yes, please.
Yes, ma'am. Start. Start. This is a start. Just a minute. Thank you. Start. Mrs. Sir is joining. We're waiting for him. Just he will join. So, our external examiners are Dr. Anurag Singh from PHU Banaras and Professor Sangeeta Sahani from IIT Kharagpur. Our Vice Chancellor, Sir, Colonel Ranjit Singh. With your permission, we are starting, sir.
Good afternoon, respected VC, sir, and all the respected panel members. I am Naboshree Bhattacharya, and today I am going to present my thesis, a study on the quality differential. A study on the quality differential in the delivery of healthcare services through public-private partnership mode. So, I have tried to incorporate the following valuable suggestions provided by Sir and Ma'am in my thesis. Moving forward. Just a second. This is the brief of what the study is about. Basically, it compares the patient's perception of healthcare quality and public-private facilities under Ayushman Bharat Pradhan Mantri Jan Arogya Yojana in Jharkhand. It investigates the quality of healthcare for both patients and caregivers' perspective. It provides the insights into healthcare availability, accessibility, impact of ABPNJY, and also successful strategies, areas of improvement. It examines the growth prospects, socioeconomic disparities, and trend in out-of-pocket expenditure, healthcare access and care quality. And lastly, how public-private partnership in healthcare could be beneficial for providing enhanced quality of care and achieving universal health coverage. The scope of the study includes examining the demographic characteristics for both patients and staff. It analyzes the types of healthcare services provided by the selected hospitals that contributes to the delivery, enhancing delivery of healthcare services, comparing experiences and perspectives of both patient and staff, and the focused analysis is of Jharkhand district hospitals, which provides the current situation of healthcare, and also it will help in policy formations, policy decisions, and improvement initiatives in Jharkhand. Actually, it is little difficult to accommodate the entire spreadsheet, so I have tried to include it through link here. Although for the brief, the total number of journal articles which I have read is 221. Total number of books which I have read is 5. And the reports are 6. Basically and majorly, the literature review included public-private partnership in healthcare delivery, quality of care in healthcare systems, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and perceived quality of care. I also have this with me. If necessary, I can also show. Moving on to the findings from the major findings from the literature survey. Quality of care is a multifaceted concept encompassing technical performance, interpersonal aspects, patient contributions, and health system impact. Measuring and improvement quality is challenging due to subjectivity, lack of standardized tools, and social and cultural influences. Public-private partnership in healthcare have the potential to improve access to quality services, but their impact on quality remains debatable. Recent studies highlight the need for greater attention to quality of care under PMJAY. Out-of-pocket expenditure is a significant barrier to accessing quality healthcare in India. Also, unmet needs in family planning persist in many developing countries. However, challenges include ensuring sustainability, scalability, and equity. Public-private partnerships under PMJAY has the potential to expand access, improve efficiency, and leverage private sector capacity. However, their effectiveness depends upon the partnership design, regulatory environment, and ensuring equity in access to care. Systematic literature review led to the following research gap. As per the best of knowledge, no evidence is found that measures the trend and budgetary allocation and actual spending on public healthcare facilities, including public-private partnership in Jharkhand. No evidence is found that measures the quality differential of public and private healthcare facilities in Jharkhand. And no study has incorporated both demand side, that is the patients, and supply side, that is the staff, perspective for evaluating quality of care. So this is my studies theoretical framework, wherein I have tried to connect my studies research objectives, questions with the theories and hypothesis. I'll just like to give a brief because I will be coming up with all the objectives and hypothesis in the upcoming slides. So basically, majorly the theories which are included are Calder-Passanati theory, utility theory.
You have already mentioned these in your thesis. I think you can come straight away to the,
Yes.
yeah.
I'll move forward, ma'am. Okay, thank you. So this is again the research design. Just to explain a bit what analysis I have conducted for what objective. So my first objective is to study the availability of basic and specialized healthcare services in Jharkhand. The data sources, as we can see here, is Annual Economic Survey, NFHS report, state health reports, trend analysis is performed. Then for the second, to study the trend of government expenditure on healthcare services in Jharkhand. Again, the similar data sources are used. Trend analysis is performed. For the third objective, to assess the need of adoption of PPP mode in healthcare sector in Jharkhand. This also includes my field work. It includes trend analysis of unmet needs based on out-of-pocket expenditure. And the fourth objective, the major objective of my study, to map the quality differential between public and private healthcare facilities in Jharkhand. Literature review and fieldwork is done, and principal component analysis, multiple linear regression analysis, Z-test of proportions, and sentiment analysis is performed. So two causal models are developed to answer the following three questions. First, why do patients select a particular hospital? How does patients' experience at hospital affect their perception of quality of care? And how can we compare the experience of two distinct groups of patients and staff? So this is the causal model 1, which shows 4 factors which impacts the hospital experience and further leads to perceived quality score as developed. This is causal model 2, which represents the perceived quality leads to the selection of hospital. Now, I would like to explain why perceived quality only leads to the selection of hospital and not other factors. Patients select a hospital. Patients select a hospital on the basis of their perception, and perceptions are established through perceived quality score, which I will be discussing how it has been calculated in my upcoming slides. There are 4 major factors which impacts the experience for the selection regarding the hospital. First is the cost of treatment. 4 factors which I have already shown as the efficiency, effectiveness, patient-centeredness, and safety. Apart from that, the factors which affects the selection is cost of treatment, distance from home, specialties available at the hospital. So cost is nullified as we have considered only ABPM-JAY empaneled hospitals and patients. Only those hospitals are considered where other hospitals are also present within the 5-kilometer radius. This eliminates the transportation cost and time taken. And only general physician OPD consultations are considered, and no specialty hospitals are taken. So these 3 are eliminated, nullified, So only thing which is left is the perceived quality score or perceived quality, care quality, which leads to the selection of the hospital. So hospitals are selected through purposive sampling, as already mentioned, that both public and private hospitals are present, which are present within the 5-kilometer range. Those hospitals are selected. Cost is nullified considering ABPM-JY. Then again, only those patients are considered which are under ABPM-JY, who uses the golden card. And simple random sampling method was used to select the patients. So here I would just like to mention that the study population includes all individuals who have ever been to any public or private hospital empaneled under ABPM-JY in the district of Ramgarh for consultation or treatment during the reference period of February 2023 to September 2023. Study also includes all medical, paramedical, and auxiliary services staff working during that reference period of February 2023 and September 2023 at public and private hospitals empaneled under ABPM-JY. So my sampling strategy is from the total of 146 private and public hospitals empaneled under ABPM-JY in Ranchi district. 50 hospitals were considered for the study. Then they were divided into two clusters, public hospitals and private hospitals. The primary survey excluded primary healthcare, the survey excluded primary healthcare centers, teaching colleges, children's hospital and specific disease treatment hospitals. Only CHCs, that is community health centers and district hospitals were considered. From Ranchi district, 22 public hospitals and 28 private hospitals were randomly selected for the survey. As mentioned, purposive sampling method was employed to collect data from 50 hospitals, including both public and private hospitals. Total number of hospital staffs were 338. Patient samples from 50 surveyed hospitals were collected through simple random sampling, and a total of 437 patients were surveyed. Two separate structured questionnaires for patients and medical staffs were used, which comprised of 24 and 15 statements respectively, that is for patients and medical staffs respectively, based on the indicators derived from the literature. Sentiment analysis was used for the qualitative analysis, and multiple linear regression was used for the quantitative analysis. Two surveys were conducted, pilot survey and main survey. So just a brief before this, in the pilot survey was conducted in the month of February 2023. This was the pre-test of the survey, and one of the hospitals were randomly selected. Total of 100 respondents were selected for both staff and patients. The Cronbach alpha value for the patients were 0.887 and for the staff was 0.833. Again, a second pre-test was also conducted during the pilot survey, which included a predetermined number of patients and staff, that is 57 and 43 respectively. This testing actually helped and served as the validation process to ensure the revised questionnaires and addressed any issues if identified. For the main survey, a total of 137 responses were gathered from the caregivers of public hospital, and total of 201 responses from private hospitals. And the survey encompassed a total of 194 patients from public hospitals and 243 from private hospitals. That is for the staffs and the outpatients both. The data analysis tool used was 5-point Likert scale, 5 being the strongly agree and 1 being strongly disagree. Now moving on to the slide. This is basically the overview of the first 3 objectives of my study and the results obtained, which I am going to discuss now. My first objective includes healthcare infrastructure, human resources for health and hospital bed availability. Under healthcare infrastructure, we have a significant concern, that is, there is a discrepancy between the required and actual healthcare facilities. There is a notable deficit in community healthcare centers. Healthcare system is overburdened. There is shortage of healthcare facilities, lower inpatient department, that is IPD and OPD both, per 1,000 population compared to the national average. Under human resources for health, we have adequate service delivery staff to population ratio and balanced healthcare workforce, which leads to quality healthcare services. Hospital bed availability also have also shown substantial growth in the number of hospitals bed over a period of time, especially between 2003 to 2020. Approximately, there was a threefold increase. For the second objective, trends in government expenditure on healthcare services in Jharkhand includes healthcare expenditures as a percentage of state GDP in Jharkhand and expenditure under ABPMJY in Jharkhand. There is a steady upward trend in Jharkhand's healthcare expenditure growth rate, and there was a resilience during the COVID-19 pandemic. Also, expenditure under ABPMJY in Jharkhand during the financial year 2015 to 20 has increased in real terms. It has nearly doubled at an average of 18% per annum. For the third objective, need of adoption of public-private partnership mode in healthcare sector in Jharkhand includes out-of-pocket expenditure and unmet needs. The trend shows that there is a fluctuation and decrease in out-of-pocket expenditure in Jharkhand. Approximately earlier it was 66%, and in 1920 it was 65%. Then the trend also shows that there is a high percentage of married women that lack the access to modern contraceptive method. As we can see for Jharkhand, the spacing method, the actual growth rate has slower than anticipated, and the limiting method actual growth rate have outperformed projections. The highlight of the role of the public-private partnership in addressing unmet needs, which includes collaboration with private healthcare providers, NGOs, and community organizations, expanding the reach of planning services, improving the quality of care and promoting awareness about contraceptive options, bridging the gap in service delivery, particularly in rural and remote areas. So this is the summary of the data analysis results of my hypothesis, which obviously I'm going to discuss in my upcoming slides. These are my alternative hypotheses, and which are the hypotheses which are accepted and which are the hypotheses which are rejected, which I'm going to discuss now. So this is my objective 4, mapping quality differentials between public and private healthcare facilities in Jharkhand. A total of 28 private and 22 public hospitals were selected from Ranchi district for the study of the implementation and impact of ABPMJY. The reliability and validity of patients' data can be shown through Cronbach alpha value, which came out to be 0.919. The reliability and validity of staff data for the Cronbach alpha value came out to be 0.933. Now, here the model basically shows the effect of the type of ownership on the perceived quality of healthcare services as received, which can be shown through this linear equation, where Yij is the perceived quality score by patient I for hospital J. Hij is the dummy variable for the ownership of the hospital, which takes the value 1 if the facility is privately owned. X dash is the matrix of patient's characteristics, which basically includes gender and age. H dash is the matrix of market characteristics, basically the nature of competition. As I've already mentioned that the hospitals were selected within the 5-kilometer range that is shown through this matrix. This is the result of the principal component analysis for the patient's data. It is little small, I understand, but it was little difficult for me to accommodate in 2 slides because I wanted to show 2 different slides for patient and staff respectively. This is the principal component analysis for the staff's data. This is the model fit measure showing the value of R and R square. R is 0.917, which indicates a relatively strong positive linear relationship. R square is 0.84, which represents 84.05% of the variance in the dependent variable can be accounted for by the independent variables included in the model. This is my first hypothesis of the study. Firstly, here I would like to explain the calculations. Yij is calculated for every individual patient, and it is the weighted average response of those questions. Weights being the square of the factor loadings discovered through PCA. We are basically interested in the value of beta here, as it explains what happens to the perceived quality score when the ownership changes from private to public. One patient uniquely represents one hospital. Male is the reference gender, and youngest age group, that is 20 to 40, is again the reference group. So the result of the OLS estimation of the parameters of the model presented in the equation, that is the perceived quality score, is regressed on being treated at private healthcare facility. And the result that we have obtained is the coefficient of the dummy variable private bears the expected sign, that is the positive sign, and indicates that the perceived quality score.
Just you understand this equation?
Yes, sir.
Or you are just studying it?
Pardon, sir?
You given an equation Yij
Yes.
is something.
Yes.
What will this equation represent if you plot it graphically?
So it is a linear equation. So there is a
There.
upward. Yes, sir. If I plot it in terms of Hij, it will be an upward sloping curve.
Read the equation.
Yes, sir. Yij is equal to alpha naught plus beta Hij.
So what is this equation? There are standard equations. Equation linear is okay. What
Yes.
does this equation represent?
So this is showing the perceived quality score.
I am asking you coordinate geometry.
Yes, sir.
What does this equation show?
This equation shows basically if there is a change in the ownership.
I am asking simply, is it a parabola? Is it a line?
Straight line equation.
So is it one straight line, too many
Yes.
lines?
One straight line.
No. Read that.
So because I am not taking that x dash and h dash into the consideration, sir. That's
See, there are how many variables? Yij is one variable,
yes, sir.
and on the right side, how many variables are there?
So there are 3 variables.
So if there are 3 variables, then and everybody is having a different slope,
Yes, sir.
then what does it mean?
3 different straight lines.
And then 3 different straight lines.
Yes.
So why are you summing and just like that?
No, sir. Actually, the other 2, that is x dash and h dash matrix, I'm not considering. If I have to plot, I will be plotting it only for Yij in terms of Hij.
Why? That's what I'm trying to tell you.
Sir, the reason is because I'm considering only the relationship between the change in the public and private.
Justify why you're neglecting some and you're taking something. At your convenience. Anyway, proceed.
Okay, sir. So the coefficient of the dummy variable private bears the expected sign, that is positive, and indicates that the perceived quality score is 11.73% higher for private hospitals compared to public ones, but it is statistically insignificant.
This is work done in this Jharkhand,
Yes. Ranchi district.
Ranchi.
Yes, sir.
So what government hospital you have taken?
So, government
Have
hospitals.
you considered aims?
Sir, I have taken only community health centers, sir. Because I have to justify it with, because private hospitals all are quite specialized. So I have considered CHC and district hospitals. And for private hospitals, I have considered those which are not, I'm not considering the specialized hospitals as.
Then do you think that the private hospitals also have this CACs?
No, sir, I have taken only OPD patients, general physician.
So that's all for the government, no? For private also.
Yes, sir, for private also.
And suppose Apollo hospital is there, so you
Yes.
are taking the OPD only.
Yes, sir.
And in CSC you are taking the governments.
Government, again, OPD only, sir.
So why you have not taken AIMS and other hospitals, government hospitals, and Ranchi hospital is there, big Sadar hospital have you taken?
Sadar hospital I have taken, sir.
Acha, why you have not taken this AIMS?
Because it is a research.
The Ranchi hospital you have dreams you have taken.
No, sir, no rings.
And how you are telling that the private entities is better than the government? The government is spending so much flagship program of the.
No, sir, I'm not saying government has failed.
Hypothesis telling.
Yes, sir, that is the hypothesis. But the result which have come is quite interesting, stating that there is no basic difference when it comes to the perceived quality score or perceived quality care. Whether a person is going to a public hospital or a person.
What you have, okay, let's see.
Okay, sir. Okay. So this is the first hypothesis, which wherein I have discussed that although the private hospitals perceived quality score was 11.73%, higher for private hospital as compared to public, but it was statistically insignificant. Now for this, for the second hypothesis, the proportion of patients who rank the quality of care as good in private hospital is higher than the proportion of patients who rank the quality of care as good in public hospital. This is my alternative hypothesis. And a Z test of proportion was conducted to check the percentage of people responding to if private hospitals are good or public hospitals are good. If the perceived quality scores are also used here to categorize the services of healthcare facilities as good or bad. Score equal to and above 75% percentile of the PQS, that is the perceived quality score, are classified as good and below it as bad. Chi-square test is also performed to check the association between the ownership of the facility and its perception of being good or bad. Here the result shows that the patients in public hospitals are more likely to rate the services as bad compared to the patients in private hospitals and is statistically significant. Then for the safety aspect of the quality differential, the result shows that the public hospitals are more likely to rate safety as bad compared to the patients in private hospital, but it is statistically insignificant. It simply means that the patients do not see any distinction between the safety at private hospital and public hospital as to be different. Now, this is the third sub-hypothesis related to the patient-centeredness aspect of quality differential. The result also shows that the patients in public hospitals are more likely to rate patient-centeredness as bad compared to the patients in private hospital and is statistically significant. The third hypothesis is related to the effectiveness aspect of the quality differential. Here also the result shows that the patients in the public hospitals are likely to rate the effectiveness as bad compared to the patients in private hospitals and it's statistically significant. This is the results from the, this is my third hypothesis, which shows the proportion of Medicare staff who rank the quality of care as good in private hospitals is higher than the proportion of Medicare staff who rank the quality of care as good in public hospital. And the result shows that proportionately larger number of Medicare staff in private hospitals rank their operations as good compared to the Medicare staff in public hospital and is statistically significant. Now, to showcase this, to support this, I would like to explain about the qualitative analysis. And again, this is the same objective, that is mapping the quality differential between public and private healthcare facilities in Jharkhand. And this is the qualitative analysis. Data was collected from Google reviews using web crawler, where the patients have left feedback about their experiences with public and private hospitals. A total of 5,735 reviews were collected for private hospitals. Now, I would like to explain how sentiment analysis was conducted by me, done by me.
You have got the data from the OPD patients, those who have left their reviews.
Yes.
OPD patients.
Yes, sir. I have selected that. It is
Right.
okay. Yes. In the first step, Google reviews were gathered in CSV file. Next step includes data cleaning and reviewing and removing special characters, punctuations and conjunctions. After translating all the reviews in English, the paragraphs are broken into individual sentences. For every sentence, attributes are identified that represents the sentences. This means that the sentiment expressed regarding that attributes, then attribute is rated as per the intensity of the sentiment in a 9-point scale. Same attributes may be given different ratings on 9-point scale due to its intensity. Afterwards, all the ratings were averaged for a particular sentiment. This is done for all the attributes, and the weighted average is the mean sentiment score for that hospital, whether public or private. As here we can see in the most frequent terms that are presented here for the private hospital as good and overall satisfaction with doctors, service and staff through the word cloud. And the sentiments that were reviewed were anger, disgust, sadness, fear, surprise, anticipation, joy, trust, and overall negative and positive. So the mean sentiment score for private hospital is 0.3681, indicating the overall positive sentiments towards them. Moving on to the public hospital. A total of 3,054 reviews were collected for public hospital. The most frequently used expression is good, doctor, treatment, available facilities, service and staff, as we can see in the word cloud. Again, the sentiments that were reviewed were anger, disgust, sadness, fear, surprise, joy, anticipation, trust, and overall negative and positive responses. The mean sentiment score for public hospital is 0.31152, indicating the overall positive sentiments towards them. Hence, the test for difference between the mean sentiment score, the hypothesis is the mean sentiment score of private hospitals is greater than that of public hospitals. We test this hypothesis by calculating the independent sample t-test statistic. And the critical value for t-statistic with 369 degrees of freedom and 5% level of significance is 1.96, which is smaller than the calculated t-statistic. Therefore, the null hypothesis is rejected. This implies that the mean sentiment score of private hospital is greater than the mean sentiment score of public hospitals. Since the difference between the mean sentiment score is positive, we can say that private hospitals in general have higher positive reviews than public hospitals. The following are the implications of the study, theoretical implication. The study's findings affirmed that new dimensions to existing research on healthcare quality differential can be added. Key affirmations include the lack of significant quality differences between public and private hospitals under ABPMJY, aligning with mixed results from other LMICs, lower middle income group countries. Novel contributions include the importance of considering both patient and provider perspective in assessing healthcare quality, providing empirical evidence on quality differential under ABPMJY in Jharkhand, highlighting the limitations of linear model specification in capturing and multidimensionality of quality perceptions, insight on PPP's potential and improve access and quality in underserved areas, and role of competition in driving quality improvements beyond public-private distinctions. The study addresses critical gaps in the literature, offers methodological insights, and provides evidence for policy discussions on the role of public and private providers in achieving universal health coverage in resource-constrained settings. Implications for government ministries, departments, and administrations. Fostering and strengthening public-private partnerships in healthcare sector by aligning incentives with health outcomes and quality, implementing strong monitoring and evaluation, and engaging with local communities. Develop comprehensive quality assessment frameworks incorporating multiple dimensions. Support research initiatives addressing gaps in healthcare quality and universal health coverage, and prioritize capacity building for healthcare administrators, quality improvement specialists, and PPP managers. Strengthen capacity and motivation for public healthcare providers through training, mentoring, and supportive supervision, adequate resources, and initiative for quality improvement. Implications for hospital managements. Strengthen the capacity and motivation for healthcare providers through training, mentoring, supportive supervision, adequate resources, and incentive for quality improvement. Improve infrastructure and supplies, enhance patient engagement, establish robust monitoring and evaluation system, promote a culture of quality and safety, and address social determinants of health. Implications for universities and research institutions. Engage in collaborative and interdisciplinary research to develop and evaluate innovative PPP models. Invest in developing robust methodologies for measuring quality differentials, explore innovative approaches to data collection and analysis, and build capacity for quality improvement through specialized courses, workshops, and certification programs. Actively promote translation and dissemination of research findings to inform policy and practice. Engage with policymakers, healthcare providers, and the public, and facilitate uptake of research evidence into decision-making process. Contributions of the research. These are the contributions of the research. This is basically one of the first studies that compares patients' perception of quality in public and private facilities under ABPMJY in Jharkhand, India, addressing the gap in the literature. It is one of the first to investigate quality of care from both patient and caregiver perspective, offering a comprehensive assessment, provides insights into healthcare availability, accessibility, and impact of ABPMJY, examines growth prospective socioeconomic disparities, highlights the association between competition and perceived quality ratings, emphasizing the importance of market dynamics beyond public-private distinctions. These are the limitations of the study. Reliance on self-reported data introduces potential response bias, and complementing perceived quality measures with clinical outcome data could provide a more holistic assessment. These are the scope for the future research. Expand the study to other districts and states to compare quality differential under ABPMJY across regions and conduct longitudinal studies to track changes in quality differential over time. Explore factors like working conditions, patient load, and resources in public and versus private hospitals to gain insights into drivers of quality differences. Complement perceived quality measures with objective clinical outcome data for a holistic assessment of quality differentials. Develop and validate comprehensive quality assessment frameworks, incorporating patient, provider, and health system perspectives for ongoing monitoring. Study the influence of accreditation, regulation, and payment mechanisms on quality of care to identify effective policy. These are some of my publications. I have also presented my paper on quality divide at IIM Kashipur, and recently 2 papers on PMJAY has been accepted for presentation at IIT Roorkee. I have not included those 2 papers here. And most importantly, I would like to express my deepest gratitude to my esteemed research supervisor, Dr. Satyendra Kishore sir, for his invaluable guidance, unwavering support, and constant encouragement throughout my research journey. His profound knowledge, insightful suggestions, and meticulous attention to detail have been instrumental in shaping this thesis. I'm truly grateful, sir, for his mentorship and the time he dedicated to reviewing my work. I would like to acknowledge the ICFI University Jharkhand for providing me with the opportunity to pursue my doctoral studies, for the excellent academic infrastructure and resources that facilitated my research work. I especially thank Honorable Vice Chancellor, Colonel Dr. Ranjit Singh, ex-Vice Chancellor Professor Dr. Raman Kumar Jha, ex-Vice Chancellor Professor Dr. O.R.S. Rao, Registrar Professor Dr. J.B. Patnaik, Assistant Dean Dr. Rajkumar, Controller of Examination Dr. Rumna Bhattacharya, Dr. Pallavi Kumari, Dr. Nidanesh Jha, Dr. Manish Kumar, and Professor Dr. Hariharan for their constant support, guidance, and encouragement. I'm also grateful to all the academic and non-academic members of ICFI University Jharkhand for their support during my coursework, presentations, and seminars. I extend my heartfelt thanks to my beloved family, especially my parents, for their unconditional love, support, and understanding. Their belief in me has been a constant source of motivation, enabling me to overcome challenges and pursue my academic goal. Here, I would like to thank, although I have not included, 2 people who have supported me like anything. One is Dr. Arohi Anand, and another one is Mr. Animesh Khan. They have supported me in my PhD thesis like more than family, rather. I am indebted to my professors during my college and university years for laying the foundation of my knowledge and nurturing my research skills. Their teachings and guidance have played a crucial role in shaping academic career. Lastly, I extend my gratitude to my workplace, Amity University Jharkhand, for their support and understanding throughout this challenging yet rewarding journey. The conducive work environment and the encouragement from my colleagues have been instrumental in the successful completion of this thesis. Thank you all for being an integral part of this journey.
It's the same things. Your candidate.
I would like to give a chance to one of my very favorite, she is Sangeeta Sahani. She's from IIT. So let Sangeeta please ask, then later on I will ask.
Thank you, processing. You're my senior. You should be asking first, right? Nonetheless, thank you for your kind gesture. Okay, so I don't have much any more. I mean, I've already given a detailed report. I'll ask you a couple of questions, Naboshree.
Yes,
First comes from my report to you. I had mentioned in my report that I found your thesis title a little long,
yes,
but but today also I see you've not changed that, right? So you did not consider it important to change your thesis title.
No, nothing like that, ma'am. Actually, I discussed with sir, and it was already registered that way, so I had no other choice in that, and I actually have no power in my hand as such.
Okay, no problem, no problem. Okay, now something again which I saw today,
Yes, ma'am.
again in your thesis, in your PPT, not your thesis, but your presentation. You have, I mean, I've written that don't write that no study has been conducted, but you
Yes, ma'am.
did say no study has been conducted in Jharkhand,
Yeah.
right?
Ma'am, initially I have mentioned as per the best of knowledge.
Yeah.
If I could go back to my slide, I can actually show you that. I have
No
tried.
problem, no problem. If you mentioned that, it is fine. Maybe
Okay,
I
ma'am.
missed out on that,
Yes,
right?
ma'am.
Because we always live in bonded rationality. We
Yes,
may
ma'am.
not know everything, but there will be something which exists somewhere. So it's always best not to make such sweeping statements, right? You never know what may be there already, and it may have missed your eyes or your research supervisor's eyes or ears, but something may be there, right? So it's safer always to mention that as per your information or your knowledge. Um, I really liked the way you explained your research methodology and how you tried to draw a linkage on your research questions, objectives, and your data source analysis. So that was really something good. Now, I'll just come to a couple of questions from my side, which I've also shared in my report, and I hope you've gone through those questions.
Yes,
So I saw your causal model and I saw some overlaps in your construct. So how did you take care of multicollinearity issues in your causal model?
Ma'am, actually, the VIF value came under 3, and the questionnaire were actually based on the established scales of health wall and surf wall. So
Hmm.
there was basically no problem of multicollinearity as such. So I have
Hmm.
proceeded further like that.
So it's always best also to go in for an expert validity. You decided not to go for an expert validity because it's always good to go in for an expert validity because that gives you, I mean, it leaves behind any scope for any, because many times they say that statistically, while we look at statistical findings, there may be some loophole, some error somewhere because I distinctly don't remember it now, but I could find some problems in your model where I did. That is the reason I put this question there. That how did you address the multicollinearity part? So what prevented you from actually getting these constructs tested through an expert validity?
Ma'am, actually, initially there was no such causal model, but after my pre-thesis defense, I was guided through that how have I chosen a patient or a staff from different hospitals and how I have come across that. So,
Hmm.
with my little knowledge, I have tried to incorporate it in my study. That is why maybe I have missed out on the suggestion as you have provided. So as per my knowledge, I have tried to do the little possible which I can.
Hmm. Okay. You have tried to study this in Jharkhand, and you did talk about some cities of Jharkhand which you took. Which are the cities which you took from Jharkhand in your sample?
Ma'am, I have considered only Ranchi district.
Ha. Now, Ranchi is one of the developed ones, right?
Yes,
What
ma'am.
if you had studied and done this study and extended this study to other tier two cities? Because you've taken a tier one city of, of Jharkhand. What if you had extended it to tier two cities?
Ma'am, I think if I consider my causal model, it has taken care of both the cost and difference. So if I take that, there should not be much difference between the tier 1 and tier 2 cities.
No, 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 no,
I have
no, 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 no. See, you're looking at health and quality and service and quality. What kind of health and quality and service and quality you're going to get in hospitals at Ranchi? You cannot afford think of getting it in hospitals which are not in a state, capital, right?
There may be less number of hospitals also. That is, and even the
Are you talking about the number of hospitals or are you talking about the quality of hospitals? See, there is something, I don't confuse between quantity and quality. There may be less number of hospitals, but they may be very good in quality. On the other hand, you may have many hospitals and they may be very bad in quality. Right? Are we
Yes.
talking about numbers or are we talking about quality?
Quality.
Then
Yes, ma'am.
even a one good hospital, and if it's a quality hospital, matters.
Yes, ma'am.
Then yes or no?
Yes, ma'am.
So if you had extended this study to tier 1 and tier 2 cities or tier 3 cities, I mean, how do you think your findings would have differed? I will not agree if you say that different findings would not have differed. Findings would definitely have differed.
Maybe the quality there and the differences which I have seen between the public and private, there is public hospitals might be better in some of the parameters. As I have seen here, only safety aspect there is no difference, or the perceived quality care there is no such difference. But
Okay,
there
tell me
is
one
better-
thing, 1 minute.
Yes, ma'am.
When we talk about quality, we are talking about expectations, perceptions, right?
Yes,
If you're
ma'am.
going to talk about expectations, a person who's a literate, educated person, his expectation would be very different to a person who doesn't know anything.
Yes, ma'am.
Then, so if you're going to ask a person who doesn't know anything about healthcare, uske liye to everything is good.
Correct, ma'am.
Then
Correct, ma'am.
that is the reason why Sarvakol, in fact, has come into question. And that is why, Corner and Taylor Sarperf model is a people have said that is the model which should be preferred over Sarvakol. That is the
Yes.
only reason why Sarperf is supposed to be better. Of course, people don't use Sarperf. That's a different reason. I myself, when I did my study, I did not use Sarperf, but that is one of the criticism of the Sarvakol. That it brings in a lot of expectations, and expectations across your sample will be very different. So if you take people in tier 1 cities who are more informed, aware, literate, and you're going to try to compare them with people who, and their expectations with people in tier 2, tier 3 cities who are not even aware, informed, they're not literate, then, I mean, how are you going to draw a comparison?
Ma'am, I was just thinking if Ayushman Bharat Pradhan Mantri Jan Arogya Yojana could play a role, because generally poor people have the card. They might not be that well informed even in tier 1 or tier 2 cities. That could be a case.
अरे चाहे जितनी भी योजना हो जाए, people तो are people, no?
Yes, ma'am.
You have to understand that.
Yes, ma'am.
Then even doctors, I mean, the kind of facilities a doctor can get in terms of diagnostic equipment and facilities, other facilities in a tier 1 city, he or she will not be able to get in the tier 2, tier 3 city. That is the reason many of the doctors are so frustrated. They don't even get proper basic health equipment. ऑक्सीजन सिलेंडर नहीं मिलता उनको, प्रॉपर बेसिक पैथोलॉजिकल इक्विपमेंट नहीं मिलता उनको. Okay, my last question to you. If you were to do this study again, how would you conduct it?
So now as
What
per
would
the,
you do? What would you do if you had to do this study again?
I would consider the suggestion as given by you, ma'am. If I have to consider
That is a very diplomatic question, huh? That is a very diplomatic answer you're giving me. That if you have to do this study again, you want to take my suggestions, huh?
Ma'am, your suggestion is quite valuable, because I was thinking of considering taking this to other states or maybe other districts of Jharkhand as well.
Don't take off states, talk of first the city.
Yes, ma'am. So if I have taken only Ranchi district, if I expand the study to other districts, that those districts might not be as developed as Ranchi district. And now since I feel I might modify some of the questions or the approach, the way I have gone, or the selection of hospitals, that could be different.
Okay, I'm done. I don't have any other questions. Thank you so much for your time, Naboshree. Thank you.
Ma'am, for your time and suggestions. Thank you, ma'am.
Thank you. Yeah, I'm done, Dr. Professor Bhattacharya.
Yes.
Rumaji, I'm done. Yeah.
Dr. Anurag,
Yes, madam, I'm here. It was really a great pleasure to see one of my, very uh, close to all the students of 94 and 96 batch MBA from Bundelkhand University. Professor Sangeeta Sahani, we used to remember her. And, after passing almost 29 years, the first time I'm seeing her online. So I had a talk with her many times, but this is really a great pleasure, and the credit goes to Roma ma'am. So Roma ma'am, thank you very much. Thank you very much. And such a, after taking such a wonderful viva voce by Professor Sahani, nothing is remaining because she has almost touched each and everything from left to right and top to bottom. But since the formality is there, so I will definitely do the remaining part. Uh, uh, so the candidate, I would like to tell you that I have already checked your thesis, and almost after giving my suggestion or my recommendation, particularly to another on based on the work which you have performed, I can say that I was satisfied with the work. But only thing which I need to check over here whether this work has been done by you or some other person. So this is the thing which I can check simply based on the certain queries or observation which has come to my mind.
Yes,
So 4 or 5 questions are there, and I think you will be able to give the answer. My first query is that you have taken two approaches in order to analyze the data. That is qualitative and quantitative both, right?
yes, sir.
That is sentiment analysis and multiple linear regression, correct?
Yes, yes.
So how did the condition prompted you to go for these two kind of analysis altogether? Why you haven't taken some other approach in order to analyze? Because if we look at the model, it say that few other approaches would have been adopted by you. So
Yes.
you please try to give the answer, especially on this part.
Sir, initially only quantitative analysis was there. That is linear regression model. I was going through a research paper by R. Sukumaran published in 2020. So when I was reading that paper, I thought I can adapt that equation as in my. It was not developed exactly by me. I have adapted that equation from other research work, and I was almost done, but then my supervisor, Dr. Satyendra Kishore sir, he asked me to incorporate a qualitative analysis, either focus group discussion or maybe some other technique to make my study complete. So later on, I thought that since I have completed my data collection and going back to the villages and again getting the reports from the similar
No, no,
kind of.
my question is something else. I am simply asking that how these two analyses they are fit in your work. Looking at some other person's work, we cannot say that this was the requirement of my work.
Yes,
My work was something else, but adopting the approach which was followed by some other person, probably this will never be the answer. How did you select that these two type of analysis are were the requisite of that particular moment when you have decided to go for these two kind of analysis?
so initially I thought that quantitative analysis was justify and give me in the results for the parameters which I have already discussed,
So
like
you wanted to decide the qualitative and quantitative analysis both, isn't it?
yes sir.
When you have decided the quantitative analysis multiple linear regression, why haven't you gone for, structure equation modeling?
Why have I gone for sir linear?
Why you haven't gone for structure equation modeling?
Sir, actually I was reading then, and I thought I can use this linear equation. Maybe I have simplified my work a little with that.
Okay. We need to find out the answer that why you have gone for multiple linear regression, right?
Yes.
Now, another query which I have, if we go with the, see, I have prepared certain questions based on the words you were speaking over there. They're not many in number, three, four are there. Since you have done a sentiment analysis, so as far as sentiment analysis is concerned, they are again of various types. Okay. Do you have any idea that what are the different types of sentiment analysis?
No, sir, I was a novice and I have just did as per my study. So it is a very basic sentiment analysis. In the
No,
name,
basic sentiment analysis that can again be the emotion based, it can be the, you know, fine granted, it can be the aspect based, etc., etc. So, have you checked that since you were going with that analysis, have you checked which kind of analysis required, especially over here? You have shown the clouds, you have shown the word cloud, etc. Based on that, I have looked at that one. The result which has given that for the hospital doctor, I remember the cloud. Okay,
yes.
so, what prompted you, and which kind of analysis prompted you to go with this kind of analysis? Because again, that is again of three or four types. In different books, you will find different types of analysis.
Yes. So
Okay.
actually, yes, sir.
Yes, please. Please.
So actually, what I thought that since uh, I can catch. This is the basic instinct which came in my mind that I am doing a quantitative analysis, but I might be missing out on some of the empathetic part of the patients which they want to discuss without, when I'm asking, they might not speak out everything what they feel about. I just thought that they can reveal their sentiments. So that was the first thing which came in my mind that I can do
Okay.
this to catch their
Okay.
attention.
While analyzing it, which tool you have used?
Sir, I have taken help from the university and I have used R software because it was,
R software. R software.
yes, sir.
And for the multiple linear regression, which software you have used?
So R itself.
R itself. Okay.
Yes,
So that is the one commonness in the analysis which you have performed.
yes,
Now, my another question that goes with the theoretical part.
yes.
You have looked into it, and as I was looking at it through, thesis, I found that there's a combination of three theories, isn't it?
A combination of, sorry, sir.
You have integrated three theories.
Yes, sir. Three theories. Yes, sir.
What are those?
So Caldor-Passanity theory, utility
Uh,
theory, and
uh,
Pareto optimality theory, basically that I have used. And apart from
Pareto
that,
optimality principle.
yes, sir, Pareto optimality principle.
Okay. Now tell me, this Passanity theory that is directly linked with the capital as well as with the different kind of workers which are available somewhere in the industrial setting.
Yes,
As far as the utility theory of value, that is again linked with the similar kind of setting, especially which it has been used very much in assessing the workers in any of the industrial setting.
yes,
Correct?
yes.
So since your part is something different that goes with the hospital, etc., etc., how these two theories that gets fit into your work?
So basically, Caldor-Passanity theory explained why private healthcare focuses on profitable markets because, and the utility theory basically addressed the difference between the patients and the providers.
Patients and the
And the providers,
providers.
like healthcare staffs, yes, sir.
Does this theory talks about in the same fashion, or you have tried to fit that particular theory in the in your context?
So for the utility theory, are you asking, sir?
Oh, you need to check it out. Okay, you need to
Okay, sir.
check it out.
Okay, sir.
You need to check it out. You should be very much cautious by giving the answer because your work has been performed and it is about to be awarded. That's why I'm
Yes,
saying. And
yes,
in
sir.
case if there is any doubt, you immediately say, "Sir, I am still unclear on that." That is a better answer. Okay. Now,
Yes, sir.
another thing, one of the question which is coming to my mind that
Yes, sir.
is related with the, you have checked the Cronbach alpha, correct?
Sir, I have checked.
Cronbach alpha you have checked. Am I
Yes, sir.
audible?
Yes, sir. Yes, sir. Yes, sir.
You have also checked McDonald omega.
Yes, sir.
Why these two? Why not one?
Sir, actually, it came out as in the same way when I was calculating in art. And since I'm still learning, I thought I can keep both so that I can show that it
Which
is.
value is better? Should I adopt McDonald omega or the Cronbach alpha?
So
Which is better option?
I have discussed Cronbach alpha value even in the patient survey.
Is there any variation between the values of Cronbach alpha and McDonald omega?
There was a minor difference in points.
Minor difference, because the minor difference comes.
Sir, to be very honest, I have no much idea about this. I have kept it because while calculating, I got both the results. And while discussing, I have discussed only Cronbach alpha value because I was clearer on that part, better than McDonald's.
Okay, okay. Okay, my last question again related with the work which you have performed. That is, while going for checking the multiple linear regression,
Yes.
have you checked the measurement properties? Which measurement properties you have checked? आपने कोई measurement properties check किए हैं? कुछ measurement properties check की होंगी आपने?
Sir, if you could guide me a little more exactly on what I might not
See,
be catching.
yes. Since while going for the calculation of the multiple linear regression, you have checked the factor loading. Okay,
Yes.
McDonald omega, Cronbach alpha, you might have checked the multicollinearity as ma'am was asking you. Okay, VIF values, they were reported. Okay, but at the same time, while going for the multiple linear regression, you need to check the residual error. Have you gone with that? And normality of the residual, that also needs to be checked. Homoscedasticity, that also needs to be checked, because I was not finding it. That's why I ask you that what prompted you to go for the analysis with the help of a multiple regression. Okay.
Okay, sir.
So
Yes.
anyway,
Yes.
your performance, especially in the presentation, that was very good. You have really shown a very good gesture, especially to combine various things, and work which was performed, that was also a good one. And remaining part, I give the chance to ma'am Professor Sangeeta Sahani to please take away and to continue with the further proceeding. I am done from my part.
Thank you, sir. I will definitely go through the valuable suggestions. I'm still reading. I'll go deeper into the econometrics part of it and will get the work done for sure.
Yeah, I don't have any other questions. No.
So Roma ma'am, please continue further.
Yeah, you go your title, just go to the first slide. What was the title, change in the title that Professor Sangeet suggested, why have you changed that?
Until you stop.
If the customer provides business, you can. Just like, just black, no?
Yes, sir, yes, sir. I'm trying to do this. No. Just a second, sir. I don't know why it is not moving. So,
Because of function.
slide.
Okay. This is your topic,
Yes, sir.
a study on the quality differential in the delivery of healthcare services to public private partnership mode.
Yes.
And what was the change that the honorable professor suggested you?
Ma'am actually asked me to make it a little shorter.
Shorter means?
Shorter in the sense it is little lengthy to read. That might be the case. Ma'am might have asked me to reduce the. So actually, it is not in my hands. Just go ahead.
See, when you are doing a research, the topic also gives an impression how focused you are. What are you researching at?
Yes.
So I just wanted to know what was the exact thing man told you to change.
Ma'am has actually asked me to. I'm showing you, sir.
No, this is PPP mode. This is public-private partnership mode.
Yes.
But your work is something government and private. Okay? This is a PPP mode.
Sir, actually,
This is not a public, yes?
sorry, sir, to interrupt. Actually, I have taken Ayushman Bharat Pradhan Mantri Jan Aroగ్య
That is something
which is
different.
a public
That
right
is something different.
So all the point that I want to say,
Yes.
there is nothing like that. We cannot change the topic after our honorable external. He has suggested. If there are problems of who holds that power, please come back to me for everybody. Okay? Because to me also this topic appears to be a little too broad-sided, not very focused on it. It needs change. Anything. Now we go to your third last slide.
Oh, okay. Then I should stop.
Share. I don't take this full frame, go to the last slide.
Yes. Third last slide, sir. Yes. So limitations. Scope. This one, sir.
Not publications, but then go just scroll down.
Publications, sir.
Not acknowledgements, not publications. Not the scope for future research.
Okay.
What is this?
Limitations, sir.
Not limitations. Yes, contributions as well.
Yes.
So you say that this is how you have contributed. First, study to compare the patient's perception of care quality in public and private facilities under any whatever is in Jharkhand area. So this yours is the first study. Just because yours is the first study, it should be given you credit.
No, sir. Nothing like
Like
that.
we have in his book, different kinds of freak and bizarre phenomena for which people are holding the record. So just because we are first, the second one is one of the first to investigate quality care from both patient and caregiver perspectives, offering a comprehensive assessment. Okay, provide insight into healthcare availability, accessibility, impact of Atal Bihari, that Yojana, successful strategies, areas of improvement and trends in hospital ability, examines growth prospect and final high level of social duty. Now, what do I do with all your contribution of about 6, 7 that you have did? Shall I keep your thesis in the library as a decoration piece? That is option one. Option two is there is any portion in it which I can formally think that you have added to the bank of knowledge and therefore I should include in my MBA or BBA syllabus somewhere. Third is, shall I send to the government to do something? Fourth is, shall I send it to the private hospital to do something? Fifth is, shall I circulate among the society through the NGOs that this is what you do, then you will get a good service, and this is what you do, will not give.
So thank you for the suggestions actually. Actually, I was thinking, sir, that although it might have some lacunas and flaws, but I was thinking if I could give this study as suggested by sir also, that to the government, and I can expand this.
That's what am I asking. Government sector, suppose somebody is there.
Yes.
Now take any two matching hospitals in Ranchi which you have surveyed. Name them, one in private and one in one of the government hospital. Any two.
Sir, Medanta and Southern Hospital.
Vedanta and Southern Hospital. So Vedanta, have you studied what is the total budget of Vedanta in a year?
No, sir.
Budget means total expenditure of Vedanta in a year, annual expenditure of Vedanta.
No, sir. I have only
You're not.
taken the number of things.
Have you studied the total expenditure by the government on Southern Hospital Ranchi?
No, sir.
You do not. Now, if you have not studied, so what is the cost per patient that requires as a guideline to be adhered to? Something like that, either by the government or by patient, that per head, per patient expenditure in a good hospital in the league of Vedanta and Southern Hospital Ranchi should be this much per patient per year. If you are lower than this, you are heading for a bad service. Better than that, you are heading for a good service. Can you tell me those figures?
That's okay.
You will be horrified to know that the total expenditure by the government on the hospital, the parameter that I am giving, is much more than what the private hospital spends. So where is the proof?
Sir, I have actually tried to capture through the number of.
I'm saying this research is of no utility. You may be the first one. Because whatever expenditure they do, they get profit out of it. The government doesn't take any profit. So subtract their profit and see how much of the expenditure the private hospital incurs per patient per year. Average. And see the same thing about the government. The government one is much more than this. And still you are saying, and everybody says, because this is none of them is a surprise. This is a well known thing. None of the Yojana is working, nothing is working, then what's the problem with the healthcare system? So it's okay as an academic research, but anyway, so this is what I have taken. So 2-3 things I request the controller of research. The first thing that no scholar henceforth will come and read the slide during the presentation. And the maximum time they will take is 45 minutes to 1 hour. You will prepare your presentation, you will not read your presentation. Because your presentations have whatever your thesis is that would have been already read by the examiners, either internal or external. You present your case. The second thing is that any comment that comes from the external examiner or from internal examiner. The supervisor along with the student must come and discuss with me. They have to be honored and implemented. And the third thing that I told you, before you allow any topic, when any supervisor decides that now my candidate is ready, you have to ask if he is ready or the candidate is ready and the thesis is ready to be defended, what are you going to do with this thesis now? Is it to be kept as a mere decoration piece in my library or is it to be used? I find no utility in this. Anything will proceed. Please do the comprehension whatever it is.
Stop very. Best praise for still the best praise.
I would have loved to know what it takes, what ails the government sector, despite so much of expenditure being happening.
Okay, sir.
Yes, Sangeeta, Madam, and Dr. Anurag Singh, can we declare the award of PhD of Naboshree with your permission?
Yeah, permitted.
Yes, you can declare her awarding the PhD today.
Oh, sir. Yeah, you can't be there either.
My congratulations to the candidate.
I would request Registrar Sir and VC Sir to kindly.
These are the things.
Yes, sir.
Anurag sir is saying.
Yeah, Anurag sir.
Dr.
No,
Naboshree.
nothing. I was simply congratulating the candidate.
Thank you so much, sir.
Yeah, congratulations, Dr. Naboshree.
Thank you, ma'am.
Rishikesh Professor sir.
I would request VC Sir, our Honorable VC Sir to kindly come forward and declare the result.
On the recommendations of the validation committee, I confer hereupon the degree of the Doctorate of Philosophy upon you.
Thank you very much. Can we leave now?
Thank you, sir.
Thank you very much. Thank you. Okay, Sangeeta, we'll keep in touch because I rolled back, 30 years back and remember number of things. Anytime if I find, I will definitely call you.
Sure.
Okay, your performance, everything.
Yes.
Okay, thank you.
Thank you,
very much.
Professor. Thank you, Professor Bhattacharya Rumal. Bye-bye.
Thank you,
Thank you,
ma'am.
sir. Thank you.